Another interesting strategy that is being tried recently to decrease the incidence of BPD is inhaled nitric oxide. And nitric oxide is one of those beautiful examples of the success of translational research. And it has actually led to the winning of a Nobel Prize in medicine in '98 by these three researchers that have over time contributed to understand the biology of nitric oxide. And we as neonatologists, we have harnessed one of the properties of nitric oxide as a vasodilator. And this is how we started to actually use nitric oxide in the clinic. And you all know about the transitional circulation, and that the fetal circulation is characterized by high pulmonary vascular resistance and low pulmonary blood flow, and all of the blood is shunted directly through the foramen ovale or the ductus arteriosus back into the systemic circulation. And at birth, there's a dramatic change within minutes that allows the lung to take over its function of gas exchange after birth. So pulmonary blood flow increases dramatically, pulmonary vascular resistance decreased, and the shunts will close over time. And the mechanisms or the birth-related stimuli that induce pulmonary vasodilatation at birth had been described many years ago, and we know that ventilation by itself, oxygenation, and shear stress contribute to pulmonary vasodilatation. These are recordings of left pulmonary artery blood flow or mean pulmonary artery pressure monitored in fetal sheep that are still connected to the placenta. And what these researchers did, they applied ventilation, hypoxic ventilation, to the fetal sheep, only to show that if you distend the lung without actually giving oxygen, you have a dramatic increase in pulmonary artery blood flow. If you add oxygen to mimic birth, you get an additional increase in pulmonary artery blood flow. Likewise, shear stress, which is basically the friction of the cells against the vascular wall, causes an increase in pulmonary blood flow. And this is mimicked in this experiment by compressing temporarily the ductus arteriosus. But the mechanisms, how these birth-related stimuli mediate vasodilatation at birth, were unknown. And this is relevant, obviously, for persistent pulmonary hypertension of the newborn. And before nitric oxide, the treatment was symptomatic, and we did all these things that are not good for the lung, but for the sake of achieving pulmonary vasodilatation at birth. And so we used high pressure ventilation, high rate, FiO2 of 100% because oxygen contributes to vasodilatation, pulmonary vasodilatation. We used so-called selective pulmonary vasodilators like tolazoline or prostacyclins, and we were trying to drive up the systemic pressure with inotropes to be above the pulmonary artery pressure. One thing about these selective pulmonary vasodilators was that, yes, they achieved pulmonary vasodilatation, but they also achieved systemic vasodilatation, or some systemic vasodilatation, which is not helping our cause. More importantly, it also worsened ventilation and perfusion mismatch, because given intravenously, prostacyclin would also flow to the areas in the lung where you have no gas exchange, and where the lung sets up a protective mechanism of hypoxic pulmonary vasoconstriction to divert the blood from the non-ventilated areas to the ventilated areas. So you had a double jeopardy here. And that obviously led to often to the use of ECMO. And then these researchers publish in an obscure journal that we don't read these results in 1980. So yeah, Nature, it's written there. And so what happened is that Zawadzki was Robert Furchtgott's technician, and he mounted rabbit aortic rings between two wires to monitor the constriction and relaxation of this blood vessel in response to various pharmacological agents. And so he did that all the time, mounting those rings, and every time he got this result. He constricts with noradrenaline, acetylcholine doesn't do anything. And then one day, all of a sudden, he obtains vasodilatation. And so he was all worried, does these experiments again, and then finally he has the courage to show his supervisor those results, thinking that he's going to lose his job. And but Furchtgott did one thing. He listened to the results and thought, okay, what does it mean? So he reasoned that over time, Zawadzki had just gotten so skilled at mounting those vessels in those rings that he wasn't damaging the endothelium. So then they did on purpose these experiments where they would hang a rubbed ring, meaning depleted of his endothelium, into the system, and one ring that's intact. And sure enough, when the endothelium was damaged, there was no effect of acetylcholine, whereas when the endothelium was intact, acetylcholine caused vasodilatation. And that suggested to them that there is an endothelium-derived relaxing factor that contributes to vasodilatation. And 8 years later, this substance was then identified as being nitric oxide. And the beauty of about nitric oxide is that it is actually a gas. And so when these researchers did these experiments again in the fetal sheep, they tried to inhibit nitric oxide by giving LNA. And what you can see is when you inhibit nitric oxide release, you get a dramatic attenuation in ventilation-induced vasodilatation and oxygen-induced vasodilatation. And the same is true for the shear stress, suggesting that nitric oxide spontaneously or physiologically contributes to pulmonary vasodilatation. That sounds good. In addition, nitric oxide can be given as a gas. So this is a very good characteristic for selective pulmonary vasodilatation. So nitric oxide, when it's given to the alveoli and goes into the blood vessels, it's rapidly inactivated, so that there are no systemic effects. Not only this, nitric oxide as a gas, in theory, would go preferentially to the well-aerated areas in the lung, causing pure selective pulmonary vasodilatation while not affecting the non-ventilated areas. And these were the two Princeps studies that were published only 12 years after the discovery of nitric oxide in a series of patients with persistent pulmonary hypertension of the newborn. The group in Boston and the group in Denver showed that administration of inhaled nitric oxide significantly improves oxygenation. And several randomized trials then confirmed these studies, that you could transform the pink PPHN baby into the blue PPHN babies into pink babies. Another slide that I added here, because we were talking yesterday about some disease-related responses, and these nitric oxide trials were actually nice examples of the disease-related response to inhaled nitric oxide. So depending on the pathophysiology of the underlying respiratory distress, the use of nitric oxide would have to be modulated. The best example is hyaline membrane disease, where you have preferentially a parenchymal involvement. So in this case, you would like to use a recruitment strategy with high-frequency oscillatory ventilation, for example. And you can see that if you use conventional ventilation with nitric oxide or only high-frequency ventilation, you would get only little effect in these infants with hypoxemic respiratory failure. But if you add the recruitment strategy, the parenchymal recruitment strategy, you get the best effect. The other example is others, and these are the babies that have pure PPHN, no parenchymal involvement. You can see that in these babies, whether you use if you use high frequency ventilation, you don't get the same beneficial effect because the lung parenchyma is actually not diseased. What you need is vascular recruitment. So if you use nitric oxide, whether it's combined with conventional ventilation or high frequency ventilation, you get the same beneficial effect because what you need is inhaled nitric oxide. You could stretch it even and say if there's no parenchymal involvement, you don't even have to intubate that baby, put him on CPAP and give nitric oxide. You have to have guts for that. However, this slide shows that inhaled nitric oxide indeed decreases the incidence, the combined incidence of death or ECMO in term infants. And you can see compared to placebo babies in light blue, nitric oxide significantly decreases the incidence of this combined outcome. But what these studies also show is that 40 to 50% of babies still don't respond to inhaled nitric oxide, suggesting that there are other mechanisms underlying PPHN, or that we have to come up with a better pulmonary vasodilator. So research is not over. And this is where knowing about the intracellular signaling pathways of nitric oxide is very useful because these represent new therapeutic targets, potential therapeutic targets. And cyclic GMP inhibition with sildenafil is one example. Activation of soluble guanidinic cyclase is also a very promising therapeutic target, and I'm sure we will hear more about this over the next 5 years. So from these studies as a selective point vasodilator in term infants, investigators then tried to extend the indications of inhaled nitric oxide to preterm infants. And the initial trials were early rescue therapies for severe respiratory failure that were basically reproducing the trials that have been done in term babies with severe hypoxemic respiratory failure. I will not spend too much time on these trials. They have been, the results are summarized in these reviews by Keith Barrington. There was no effect in this population of babies with this severity of disease in terms of combined outcome of death or BPD. Likewise, there was no significant difference in the outcome of severe intracranial hemorrhage or PVL in preterm infants. The fear was that because nitric oxide interferes with platelet function, that in babies that are prone to intracranial hemorrhage, that you would actually see a higher incidence of this complication. The interest for inhaled nitric oxide to decrease the incidence of BPD has been nicely summarized in this schematic by Richard Martin. And you can see that nitric oxide has several properties, and this is probably why nitric oxide, or the discovery of nitric oxide, has led to the attribution of a Nobel Prize, because it has these many pleiotropic effects. And for example, in the lung, it can improve lung growth. It decreases elastin production. It decreases inflammation, it enhances surfactant function, and it also has some effects on the bronchi and definitely on the vasculature by increasing vasorelaxation and improving angiogenesis. And several investigators performed studies in experimental models of acute respiratory distress in preterm lambs. These are studies by John Kinsella in Denver, and he shows that inhaled nitric oxide abrogates the influx of neutrophils within the lung, here in this control animal. You can see with inhaled nitric oxide administration, almost no neutrophil influx, which is one of the very first steps of bronchopulmonary dysplasia. I showed you the slide before, where in animals that are deficient for nitric oxide, inhaled nitric oxide prevents the arrest in alveolarization. And likewise, in sheep with respiratory distress, inhaled nitric oxide improves alveolar architecture and lung angiogenesis. And this created the rationale for clinical studies to see if inhaled nitric oxide could prevent BPD in premature infants. Today, there are these 5 studies that have been performed. Michael Schreiber in Chicago did the first study, single-center randomized controlled trials, where he enrolled 207 babies of less than 34 weeks gestation that required mechanical ventilation. And inhaled nitric oxide was given at the dose of 10 ppm for 1 day and then 5 ppm for 6 days, or placebo gas. The main findings was that nitric oxide increased survival without BPD, especially in those infants with less severe lung disease. And there was a decrease actually in severe intracranial hemorrhage and periventricular leukomalacia. In a follow-up at 2 years of age, he showed that the babies that had received inhaled nitric oxide had fewer neurological disability, and this effect persisted after adjustment for birth weight, gender, presence or absence of BPD, and presence of intracerebral complications. And this was the main indication for Schreiber to promote inhaled nitric oxide in this patient population because they had improved neurological development. And more recently, the study should be published now, he had done the follow-up at 6 years of age. But you can see that compared to placebo, inhaled nitric oxide caused the babies that were treated with inhaled nitric oxide were more likely to have non-mild or single chronic ongoing morbidity, and less likely to have multiple chronic ongoing morbidities or technology dependence. That sounds like a bit of a stretch to show that 6 years later we still have some benefits. Then followed studies by John Kinsella and Roberta Ballard. And John Kinsella did a multi-center RCT, 790 babies, less than 34 weeks, and requiring mechanical ventilation. Inhaled nitric oxide was given at 5 ppm or placebo gas for 21 days or until extubation. Outcome were death or chronic lung disease at 36 weeks and IVH, PVL, or ventricular megaly. Here, babies that had to be re-intubated were not restarted on nitric oxide. And I think this is important in interpreting the results of the study. And the results showed that inhaled nitric oxide was actually efficient in decreasing the incidence of BPD, but only in a subset of babies. And surprisingly, I don't know if surprising, but the subset of babies were the ones with a higher birth weight. Those at real risk of developing BPD, there was no difference. But you can see babies that had a birth weight between 1,000 and 1,250 gram, up to 60% incidence of BPD. That's pretty high. Inhaled nitric oxide also improved or had babies that were treated with low-dose inhaled nitric oxide had lower risk of brain injury. these were then experimental data that have surfaced after these nitric oxide trials, and they confirmed that inhaled nitric oxide may have effects beyond the lung, because it was thought that inhaled nitric oxide wouldn't have any systemic effects since it's scavenged rapidly and inactivated, but it still might be released in systemic organs, attenuating, for example, here, lung-derived cytokines. And it was shown that there might be a distal delivery of nitric oxide-related metabolites through red blood cells that may lead to these beneficial effects seen in the clinical trials in the brain. And in this study, for example, in the developing rat brain, inhaled nitric oxide at 20 ppm increased vascular density and enhanced white matter myelination, and caused other improvements in brain development. And in this study, they showed even a neuroprotective effect of inhaled nitric oxide against an exotoxic insult in rat pups. This is the model that Pierre Gressens uses in Paris, ibutinate-induced lesions, and nitric oxide attenuated these toxic-induced lesions in the brain, suggesting that nitric oxide may have systemic effects. Roberta Ballard's study was a multi-center randomized controlled trials, approximately 600 babies, less than 32 weeks, less than 1,250 grams, requiring mechanical ventilation between 7 and 21 days. They gave inhaled nitric oxide at decreasing concentrations versus placebo gas, and primary outcome was death or survival without BPD. And secondary outcomes, they on the respirator, O2 requirements, and lengths of stay in the hospital. Overall, inhaled nitric oxide improved survival without BPD in this study, decreased lengths of stay, so that is an economic aspect, decreases the length on oxygen, and the interesting thing was that that it decreased lung disease severity if babies were enrolled from 7 to 14 days versus 15 to 21 days. And this is summarized in this slide. Overall improvement in survival without BPD. But when you split this, looking at how long these babies, or when these babies were treated, the benefit is completely attributable to those babies that were started on nitric oxide early on, compared to those that were started after 2 weeks. They also looked at the one-year outcome of their RCT, 85% survivors. Infants who had received inhaled nitric oxide required less bronchodilators, inhaled steroids or systemic steroids for their lung disease, diuretics, and supplemental oxygen. But there were no, in terms of respiratory outcome, no significant differences in parental report of rehospitalization or signs of asthma. This is a slide that tries to understand where the differences in outcome come from these different trials. And you can see when the nitric oxide was started in these different trials. And only the Ballard trial started nitric oxide at a later time point. And the next slide shows the dose of inhaled nitric oxide and when it was actually given. So most of the trials started early on, between 5 and 10 ppm. I don't think that it makes a difference. And the Ballard trial had a decreasing dose of nitric oxide, and they had started later on. So at this point, there was much controversy in the field whether we should use nitric oxide or not in preterm babies. And Roberta Ballard is convinced that there is a beneficial effect of inhaled nitric oxide in preterm babies on the incidence of BPD. and she is designing a new trial to come up with a better response. But more recently, the European trial was published. 800 babies in a multi-center RCT, less than 29 weeks gestation, requiring ventilatory support. Again, 5 ppm was given versus placebo gas, and the primary outcome was survival without BPD at 36 weeks, secondary outcome alive without brain injury. And clearly, overall, there was no effect on survival without BPD. The incidence of BPD was the same in both groups, and you can see it's a relative low incidence of BPD, and there was no effect on the secondary outcome. So we can discuss the differences between the trials and why the discrepancy in the results. So in summary, early rescue therapy for severe respiratory failure, no benefit was seen, and there's maybe a slightly increased risk of severe intracranial hemorrhage in this population of babies. The prevention of BPD in infants with mild respiratory distress, so a different indication here for inhaled nitric oxide compared to these studies. It's safe. It seems to be effective in a subset of preterm infants that weigh more than 1,000 grams, but I don't think that this is the patient population that we really want to target, or where we really have a problem with BPD. It seems to be neuroprotective, and economical considerations have to be taken into account given the high cost of inhaled nitric oxide. So the question now is we have to fine-tune our use of inhaled nitric oxide and determine which population is most likely to benefit from this therapy. And Alan Job showed this slide yesterday, the assessment or patterns of Pony disease amongst infants less than 28 weeks gestation. And you can see these babies that never decrease their FiO2 and go on early on to have increased oxygen requirements. They have a risk of chronic lung disease of close to 70%. And maybe this is a patient population that can be targeted in future trials, maybe also this population. And the population of babies in the Mercier trial, you know, might have been most of these babies that maybe do not need additional support or additional therapies. So the question also is, how do you position inhaled nitric oxide given the new trends in neonatology? And this is a historical cohort study, but it shows the power of compound interest, combining several strategies that seem to be, at least in retrospective studies, to decrease the incidence of BPD. And in this institution, the investigators compared changes in strategy that combined early surfactant administration, early extubation to nasal CPAP, lower oxygen saturation goals, and improving nutrition. Using these combined approaches, in this institution, there was a significant decrease in the incidence of BPD, pre-implementation and post-implementation, and a dramatic decrease in severe BPD once this institution started to embrace those potential minimalistic approach in managing these babies. And so the question is how nitric oxide can will be used in this patient population. And that's why maybe additional strategies might be more beneficial or more practical to use compared to nitric oxide. And that's the end of my talk. Thank you. So any questions about inhaled nitric oxide in preterm infants? I can repeat the question.
My question is, do you think that we should still be studying doses of 5 pounds?
So the question is, should we still study doses of 5 parts per million compared to
The higher dose of Ballard,
10 ppm? Okay, so who uses nitric oxide? In term babies. Yes. What is the dose? 20? You start with 20 and then you go down? Okay. Who uses inhaled nitric oxide in preterm babies? Okay. So is anyone using it with the indication of decreasing BPD? No? It's when they have severe respiratory failure? Okay. What is the dose? 20. And then you go down like in term babies. Yeah. So I think there has been only one dose response study that showed no differences between 40, 20, or 5 ppm. And back in France we used actually 2 ppm, and that worked as well. So I mean, your question is legitimate because they used higher doses, and they and if they were given for a longer period of time, it was also beneficial in the Kinsella trial. Who knows if the babies that were extubated would have still received nitric oxide while extubated? Maybe they would have had even a better outcome, but we don't know what is the best dose, what's the best length of treatment, and which patient population is most likely to benefit from those from nitric oxide. Oh, sorry.
Once the baby is improving and we see babies getting NO and oxygen, which one would you try to stop first?
It's a good question. So what we do, but it's, again, there's no evidence for that. We go down to 40% because we think it's safe, and then we start weaning the nitric oxide.
Okay. So you wean the nitric oxide first and then the oxygen?
No, first the oxygen, come down from 100
40
or
to
whatever
40,
it is,
okay.
down to 40, and then the nitric oxide.
And then nitric oxide.
Yeah. Is that what most of the people do as well? But again, there has been never a study that shows that this is the safest way of weaning a baby.
Listening you in the morning and thinking of you said in the morning, it should be useful using nitric oxide.
Yes.
To prevent bronchopulmonary dysplasia.
Correct.
But so should we look to the studies that have made with like looking to the ventilation strategy, the IO2 to see if it should be made a different way to work?
Yeah, so animal models recapitulate the clinical situation only to some extent, right? So then you create the rationale in the lab, and then you still have to test it in real patients. I think the trials for the indication in term babies for PPHN were very well done, state of the art, just like the surfactant trials. And they showed that inhaled nitric oxide has a beneficial effect. And then over time they taught us that, yes, we have to adapt the strategy to the underlying disease. For the indication in BPD, again, since those trials, we have made lots of incremental changes in our management of these premature babies. We give surfactant earlier. We try to put them on CPAP as soon as possible. Some try not to intubate at all. And so the question now is, is there a place for nitric oxide, and where is that place with these treatment strategies? That's why I like this, this study quite well, because it shows us that there's a subset of babies that may not need nitric oxide, right? These clearly, they don't need it. And this patient population is interesting. What's happening here? Why do they increase their FiO2 requirements, right? Are these babies that that were born in the context of chorioamnionitis, and then around 2 weeks of age or 1 week of age, they start having inflammation, which worsens their respiratory conditions? Are those babies that are severe IUGR, that don't have enough alveoli yet, they're compromised? Would they benefit from nitric oxide? These babies clearly must have very premature lungs. They never go below, let's say, 30, 25% FiO2, even after surfactant administration. So they must have some structural immaturity, but major structural immaturity. And maybe these babies may benefit from inhaled nitric oxide because of their putative effects on lung growth, lung angiogenesis. But they will need more than nitric oxide. But for now, that's the closest or the best we have, the closest to the clinic. Oops.
I always struggle with nitric oxide because, as you showed, with inhaled nitric oxide, it goes down to the alveolus. And the blood passing the alveolus at that point is the capillary, and the blood then goes on to the venous side. So how does this nitric oxide ever get to the pulmonary arteries and the pulmonary arterioles? Because it's being swept away into the venous side, and as you said, it rapidly gets, inactivated. So how can it dilate? I mean, it does, but how does it get to the pulmonary arterioles? Have you got any thoughts about that?
Nope.
Okay. Well, nobody knows. That's a pity. I thought you were going to help us. Next question.
Maybe there is. That would be amazing. So maybe there is then. It's the release of the nitric oxide metabolites that actually cause the beneficial effect.
Right.
Yeah, never thought about it.
Would you like to comment about treating babies with lung hypoplasia? Is there a place there?
Yeah, that's why I didn't put up that slide too long. So there are two sides of lung hypoplasia, or two causes of hypoplasia. Were you thinking about this indication here, or patients with congenital diaphragmatic hernia? Both?
Well, mainly, I think just pure pulmonary hypoplasia, mainly due to oligohypoplasia.
Yes. So this is very, very interesting, because who uses nitric oxide in this indication? This is it? So in retrospective study, Jean-Christophe Rosé in Nantes, he looked at the causes of PPHN in preterm babies. And most of these babies are born after prolonged rupture of the membranes with some oligohydramnios. And very clearly, these babies, they behave like this dry lung syndrome that has been described by a team in Switzerland. And Switzerland. And you can see these babies, they present with PPHN. You use relative high PIP, high volume to distend the lung, but these babies still seem to require the inhaled nitric oxide. They get a first dose of surfactant, they improve transiently. Very often they require a second dose of surfactant, and in between, I think there's a good timing to use the inhaled nitric oxide to decrease the FiO2 and avoid the volume trauma. But these studies need to be done. But very clearly, these babies have a dramatic response to nitric oxide, and after 2 or 3 days, they do fine. So it's that period of dry lung syndrome that you have to overcome.
Can I just comment on that?
Yes.
This is partly evidence and partly anecdote, but
Yes.
we had a series of babies with oligohydramnios, and really we couldn't ventilate them.
Yeah.
And we give them nitric oxide, and wow, they've gone from 100% oxygen to air.
Exactly.
So Richard Harding, who works in the physiology department, a professor of physiology in Melbourne, who's a real expert on lung development, I mentioned this to him, and he said, you neonatologists don't understand. Pulmonary hypoplasia is actually much more pulmonary hypertension than loss of lung volume. And in fact, we all know that you can manage perfectly well on half a lung. And they've got LAM studies showing severe pulmonary hypotension. And that's probably why nitric oxide works remarkably well in this situation. And so almost the problem is we seem to have got the words wrong. We call it pulmonary hypoplasia, and everybody assumes that the problem is because the lungs are, quotes, too small, and forgets the pulmonary hypertension that goes with it.
That's very interesting, because they have done these studies where they drain the fluid from the fetal sheep lung only on one side, so they can really study it accurately in the lab. And so the sequence in these babies is classical, right? Conventional ventilation, surfactant, second dose of surfactant, high frequency. He's still not doing better, and then nitric oxide, and then all of a sudden he turns around, right? So give the first dose of surfactant, but start nitric oxide early on. You will see you avoid the therapeutic escalation of then inotropes, and it's less is more. I mean, if you start the nitric oxide early on in these babies. Congenital diaphragmatic hernia is a different issue because, I mean, the meta-analysis don't suggest that nitric oxide makes a difference or that the babies are poor responders to oxygenation with nitric oxide, but still everyone is doing it, is using it. And maybe there too, over time, we changed our treatment strategy with permissive hypoxemia, permissive hypercapnia. We damaged the lung less. Maybe now nitric oxide actually is beneficial in these patients. 12:30, perfect.